Hi, everyone, and welcome to ABB Optical Group's 2021 webinar series, year number 3 in this educational series. My name is Craig Norman, and I am the moderator for tonight's terrific presentation that you are going to be receiving regarding the scleral lens category. So I'd like to begin by starting with introductions. Tonight's presentation is going to be on my best fitting tips for solving scleral fitting problems. It's with Dr. Maria Walker. We also are going to have join us a little bit later in the evening, Andy Jackson and Jonathan Meadis from ABB Optical to talk very briefly about a couple of very exciting things happening there related to scleral lenses and other types of contact lenses. So Dr. Walker has really a wealth of experience, and I'm guessing that most of you have either seen Maria, heard Maria, read Maria, something like that, because she's been quite prolific at still such a young age related to the contact lens field. She started her path in optometry at the New England College of Optometry, where she earned both the optometric degree and Master of Science, and went on to complete a residency in cornea and contact lenses at Pacific University. About 6 years ago, she joined the faculty at the University of Houston College of Optometry, where she is currently working on her PhD, and in fact, she shared with us this evening is very close to completing her PhD and other research, and is a clinical attending clinician in the specialty contact lens service. Dr. Maria Walker, thank you so much for being here tonight. We're really looking forward to hearing all about your tips for solving scleral lens fitting problems.
Great. Thank you so much. And thank you for the kind introduction, Craig. Always a pleasure to be on here with ABB. So yeah, I'm going to talk a lot about scleral lenses in a relatively short time. So I will do what I always do and give a brief overview of the scleral lens, who we fit it with, just to make sure we're all on the same page. But I'm going to go through that stuff pretty quickly because I do want to get into some of the more advanced for those of us who, like many of us, probably have fit these more than once or twice. But hopefully we all can get something out of it regardless of how many times you fit a lens. So just to orient us, we all know this is the scleral lens on the eye. I think most of us at least probably know that the scleral lens, if you're looking at an optic section, is here in the front with the fluid reservoir in between, and of course the cornea behind it. We also all probably know who wears these lenses, but definitely we can appreciate that the indication for scleral lens wear, if anything, is expanding. It's not getting more narrow. So started really with the irregular astigmatism group. So keratoconus is about 50% of our patients in scleral lenses, and then all these other different types of things that basically cause irregular astigmatism or some sort of irregularity in the cornea. The other indication that is more and more increasing as well is this ocular surface disease. So our patients with severe ocular surface disease, graft versus host, even some of our Sjogren's have really severe dry eyes, all the way to now where we're almost fitting patients that are relatively normal. So I just had a patient this afternoon whose eyes were too dry for LASIK, but she had 3 diopters of corneal sil, and so she's presbyopic, and here she is in my chair and doing really well. So more and more we're fitting these on, quote, normal corneas, which I typically will say most of them are going to have some sort of quite high, difficult to fit with a soft lens type of refractive error. And then even sports vision. So lots of people are being put into scleral lenses. So important that we're aware of all the good that we can have from them, but also understanding that they don't come without complications. And so I think if you're comfortable with managing the complications, it really can make your practice just out of this world for patients, and you'll get a lot more comfortable fitting scleral lenses by understanding how to manage some of these complications, which by just looking at these images look like they're can be quite severe, but most of them, as we'll see, are relatively manageable. And the benefits of the scleral lens almost always outweigh the risks associated with these somewhat minor complications. In terms of an exam sequence, just to run through this, right, we typically will have a patient come in for baseline testing, and we'll talk a little bit more about that towards the end when we talk about some of the complications like corneal edema and like increased IOP, which do not happen often, but when they do happen, we need to have that baseline testing. So really important to get baseline testing to see where patients are with their disease or with their ocular surface health before being placed into a lens. And then we have a dispense and we follow up with them typically several times throughout the year before we just let them go. In terms of the disease state, things that we want to consider, how much scarring they have, certainly how much neovascularization they have. Here's an example of a patient with RK in the bottom left, and oftentimes these patients, certainly once they are fit into scleral lenses, they will a lot of times have neovascularization that will come into their incisions a bit. So important to document where we start with this and then where we go after being fit with the scleral lens. And I'll tell you, oftentimes things get better, right? Patients come in with epithelial defects or epithelial staining or some early scarring, and then we put them into these lenses and it gets better. So a lot of times we aren't necessarily expecting worse, we're expecting better, but we need to know where we start so that we know where we end up. And the other thing is evaluating the disease state. Certainly, the one to remember here is MGD. I don't think any of us, even if we say we do, I think we all can do a better job at evaluating the eyelids and the eyelid health prior to starting scleral lenses, because so many of the complications, like the debris that accumulates on lenses, even the midday fogging that happens in that tear reservoir. These are all related to MGD and going to be exacerbated by, because meibomian gland dysfunction is not just meibomian gland dysfunction. It then also has implications for the inflammatory state of the tear film and of the other structures in the front of the eye. So really important to manage inflammation on the ocular surface prior to putting patients into the lenses. And then other things that, you know, patients are going to have, pingueculas, blebs, intacts. We always want to know where they're starting. So in terms of the actual fit, there's lots of different ways to start a fit. I think probably that's more of the basic kind of stuff, so I won't really get into this much here, except to say that we fit however we decide to fit. We're fitting the sagittal depth of the eye, right? We want a lens to vault over this cornea and land on the conjunctiva. So what this is showing is just 4,000 microns is the depth of this patient's eye from the apex of the cornea here to this area, which is where we determined this patient's lens was going to land. So you'll get some sort of measurement or estimate of that. A lot of times we'll use the scleral topography. So there's several different types of scleral topographers, or a few different types at least of scleral topographers. Here's something called the S-map. This is a printout from the eaglet. Those of us who may already have a Pentacam, depending on which version, there's the CSP, which is the Pentacam's version. Any one of these instruments is going to be able to build an elevation map. So it's mapping the scleral topography just like it would map the corneal topography. And I think more now than ever, many of us, especially if you have access to these instruments, are using these instruments because they, as the lens designs get more sophisticated, you're able to design more sophisticated if you have more information about what's going on with the sclera. And between these three instruments, you can find a lens that matches up with it. So I would highly encourage people, if you can, and there's also ways to do this with OCT. So if you can get a good idea of what that scleral topography is, it's typically can be helpful down the road when and if you have to troubleshoot. Again, like I said, you can use the OCT to get some information about how high. Certainly, if there's irregularities on the conjunctiva, it's a little bit out of the picture here, but you can move the eye around, measure things. When in doubt, any obstacles, so to speak, on the conjunctiva, even if you're just measuring with your slit lamp reticle, always take exact or as specific as you can measurements of these things will help you. And certainly I think my consultant friends would echo that, because that's really helpful for them when helping you design some of these lenses, which so oftentimes now have some sort of customization in the landing zone or in that peripheral zone. The other use of the OCT, this is just an example of what I would consider a hot spot. Maybe this is a graft patient here on the right. This is a graft host interface, and you're making sure that you're not touching in those areas. So I use the OCT for those couple of different reasons. Let's just look at a quick example of how we actually do the slit lamp evaluation, right? So once a lens is on the eye, we'll typically put fluorescein in. And those of us who have fit lenses for longer, it's funny, of course, just today I was putting on lens on a patient and I put it on without fluorescein because as those of you who fit more than probably 5 lenses realize, we can usually get a pretty good sense of how the lens is fitting and measure the clearance without using fluorescein. But this was a patient today where it was really close in a couple of areas. And so even those of us that have fit a lot of lenses, it can still be really helpful to use the fluorescein when you're using your slit lamp to evaluate. And so you can see a slit lamp here is low magnification, cobalt blue illumination, and you can tell just because you don't see any shadows here on Karen's eye that she probably doesn't have any areas where the lens is touching. Now, as she goes further into the slit lamp assessment, you see she moves into white light and to the optic section. So we can see a close-up of that here. And this, again, many of us are probably familiar with this, but just to remind us, we're looking at the fluid reservoir, which is the fluorescent area there in the center, comparing it to the lens thickness. I always tell students this is like your von Herrick assessment, right? You want to get a ratio of how much thickness you have compared to of the tear film compared to the lens itself. Again, I think most of us are probably pretty familiar with these slit lamp techniques. Now, again, begging the question, do we need fluorescein? And I would say a lot of the time we don't. It can still be helpful when you have very small amounts of clearance, but I think for most of us, for many of our patients, certainly patients when they're coming in for follow-ups, right? You don't take the lens off, put fluorescein in, and put the lens back on. We'll see here towards the end, oftentimes we'll put fluorescein over the top of the lens when the patient comes in to see if it goes in underneath the lens. But you're going to end up having to evaluate these in white light a lot. This is a patient here. You can see the front, that green arrow shows where the back surface of that lens is. So you can still appreciate where that fluid reservoir is. And this patient actually, and this is actually on my eye, believe it or not. And I am one of the lucky people who gets midday fogging or debris that accumulates underneath the fluid reservoir. And you can see even with not much clearance, it didn't take long for this debris to form in the fluid reservoir. So we'll talk a little bit about ways to manage that later, but this is what you would be looking at if you're seeing that in the slit lamp. This is just an example of a patient with keratoconus, and this is actually where fluorescein is quite helpful. And I think I've got this zoomed in here in a couple slides. Yeah, so we'll zoom right in. And you can see the fluorescein on these ectatic eyes is going to get really pretty thin when it's overlying the apex. Again, if we look here at the full optic section on this cone patient, they've got 4, 5, maybe even 600 microns of clearance here superiorly and inferiorly. So we don't want to have too much fluid reservoir depth, because not only can it cause issues like edema, and it makes midday fogging worse, but it's also going to make your lens decenter a little bit more. And just really, if you have too much clearance, we just know it affects the fit and comfort and just overall success of the lenses so much. So this is a good example of a good fit, but we've got just enough over that apex. I would say this is about 150, 200. We're probably closer to 200 microns. But that's, if you go much lower than that, you worry about touching, but you don't want to overvault those areas. So here's an example of what I would consider a quote perfect fit post settling. The estimated clearance on this, and this is the image on the right side I'm referring to here. Say our lens is 350 microns thick, which is the case in this particular patient. Our fluid reservoir is about 150 microns, a little closer to 200 after settling. So if you ask what's the ideal clearance, right? 100 to 200 microns, but keeping in mind that you have to really predict that you're going to have 150. Some patients might not settle that much. Some patients might settle a little bit more, but I usually expect that I'm going to get about 150 microns of settling. So 250 to 300 microns at dispense will put you at somewhere between 100 and 200 over the highest area, or the shallowest area over the underneath the lens. And so that's what I think most of us, and there's not really a great body of research in terms of looking at all the different factors and what is that ideal clearance. But I think those of us that have been seeing these patients a lot would tell you as low as you can go without touching the cornea is a pretty good idea. And you want to be at least 100 microns of wiggle room, so to speak, keeping in mind that's 1/10 of a millimeter, so a very small amount. Because then it gives it a little bit of room to settle over the course of wear, because we know the lens will settle after about 8 hours, but it's also going to show more settling after about 6 months or so. And this is just an example of settling on OCT here. So this is the basic stuff. So the rest of what we're going to talk about is more of the advanced stuff. But if anyone has any questions, I'll give you a moment just to tune in and let me know if there are any questions at this point.
Okay, there sure is. I'd like to thank everybody that did write in questions into the question box and suggest if you have any other ones as we go along this evening to do so. I'll start with the last one that came in, and that was, would the expected settling amount change with a really boggy conjunctiva?
Yeah, so again, this is where we don't really have much research per se on it, but that one I can say pretty confidently, yes. Patients, the question is, how do you really know about, right? We all can look at them and say, well, yeah, they've got some redundancy. It looks pretty spongy. But sometimes you get those patients where you think they're going to settle and it doesn't settle so much, or patients who are, really young and their eyes look so white and quiet and then it settles. So, yes, they will settle more if it's boggy. It's just kind of hard to tell what patients really have, extra spongy compressive tissue.
Okay, terrific. You answered one already relative to, do you put fluorescein in over the eye when you're over the lens when you're using it, or do you remove the lens and put the fluorescein, into the bowl and put it back on? But you already answered that in the presentation. Yeah,
and I'll talk a little bit more about that too towards the end.
Okay, great. And then has COVID changed your diagnostic lens fitting process?
Oh, yes. And you have to remember too, we're at the university, so we've got a lot of hands and a lot of people in and out. We used to, and really it's pretty simple, and I think we'll stick with it post-COVID anyways. So once a diagnostic lens is touched, it is not touched by anyone else until it goes through full disinfection, 3 hours of peroxide disinfection overnight, which at the school, works out okay. We've got usually have several lens sets and a lot, but it does some of our more popular sets by the end of a busy day. We're running around trying to get diagnostic. So every single lens that gets touched. And the other thing we've done is our plungers. Now, I know a lot of people that just give the plungers to the patients if they're used on them, which I think is a good role. We don't do that, but we also, any plunger or lens that gets touched goes into a special bin and goes in 3 hours of peroxide and then overnight in the peroxide neutralizing solution. And then, I won't go into this, but the normal, which I see going on, we also have, of course, cleaning protocols of every room, in and out, all that stuff. But certainly diagnostic lenses don't get cleaned and put on a different patient.
Okay, that is great. And then just a quick one, and then we'll move on. You did kind of answer it, and it's related again to looking at the vault. Do you evaluate the vault using white light with fluorescein? So I guess rather than blue light to fluorescein, white light with fluorescein.
Yeah. Yep, I do. It's better contrast. So the only time I really use the cobalt blue light is to see at the beginning if there's like shadows over, especially if you've got like a graph that has areas that are a little close. I'll kind of look at it, but I'm not making many decisions on that. Your contrast with the white light on optic section is going to be much better, and you can just get it brighter. So it's a lot easier to see.
Okay, that is terrific. Thanks everybody for those questions. And Dr. Walker, we're ready to proceed.
Keep on going. All right. I'm going to go through these a little quicker so we can get to the good stuff. Easy common complications. So here we're going to start talking about some of the actual complications that we see. So application, bubbles, lens non-wetting, these are the easy things, but they need to be taken out, reapplied. In the case of lens non-wetting, cleaned really well. I think most of us, if you have questions at the end, we can talk about this, but I think, if you've got a bubble, you have to reapply. You can't push a bubble out. You got to take the lens off and reapply it. Same thing I would say with lens non-wetting. There's ways to kind of wet it for a moment in the office, but at the end of the day, you end up having to take that lens out and clean it better. Here's an example, if you guys haven't heard of Progen, something that can help you with a lot of your complications, and that's what we call a kind of super cleaner. It's basically a bleach cleaner. But you can see here you've got really pretty severe deposits on a lens edge, and that cleaner will get rid of those. So if you do have patients who have chronic deposits, non-wetting issues, periodic use of this or other enzymatic cleaners, always a good idea. I always, tell patients again and again and again how much the cleanliness and the conditioning of the lens makes a big difference. Again, these are kind of the more straightforward complications. So excessive apical clearance, and how so this is a good example of when that cobalt blue filter can, and this is, if you've got the blue light on your keychain, this is something you would probably be able to see. This much clearance would light right up at you, and you wouldn't even have to put them in the slit lamp without realizing that you'd need to probably put on a lens with a lower sag. Anytime you have this dense fluorescein pattern where you can't see anything at all, you should, be able to see a faint outline of the pupil. This just looks really, really fluorescent. And then, sure enough, you do an OCT and they've got about 500 microns of clearance, which is too much. So if you have too much clearance, you're going to end up with a lot of sometimes non-specific, sometimes specific, but just ends up being an issue for most patients, not all, but most. They can have blurry vision, sort of non-specific visual distortion. This lens discomfort, which I think a lot of that is coming from how far away the lens is from the eye, right? Like this is half a millimeter at this point. So this lens is a millimeter away from where the cornea normally sits. So that eyelid has to blink all the way over that. And every time it blinks, it's pushing that lens against the eye. So those patients who come in and say, I have this, kind of headache type of pain with the lenses after an hour, a couple hours of wear, first thing I check is the sagittal depth and then, something with that landing zone. You're also going to get a lot of debris under there. And patients, we'll talk about midday fogging in a minute. I'm pretty convinced that this is a patient-specific phenomenon rather than a lens-specific phenomenon. But certainly, the more fluid you have, the more dense that fog is to look through, and it's just going to make patients exacerbate midday fogging in patients. And we know there's actually pretty recent data that the fluid reservoir does, and we've always kind of known this, but there's been some debate about it. But the fluid reservoir thickness is one of our biggest factors in terms of hypoxia. So if you can lower that fluid reservoir thickness, you can reduce the risk of hypoxia in patients. Now, in terms of corneal touch, this is an example of not your average corneal touch, right? It's easy to, you've got a lens that's touching the whole cornea. Okay, we need more sagittal depth. We need to change the base curve. Call our consultants and figure out how to do that. It's these kind of interesting cases. So the thing that's the same about both of these patients is if you look where the blue star is, the lens is touching. But if you look where the red star is and really everywhere else on that lens, you've got way too much clearance. So kind of what do you do when you have touch in one area and you're already clearing the rest of the cornea so much? You don't want to keep increasing that sag. And I'd say this is where our new technology really comes in handy, because if you've got a custom lens design or something where you can make some asymmetry in that lens design, that can be really helpful. But this type of patient, I would say, at this point, call your consultant, figure out what kind of lens design you're working with, but try to see if you can kind of vault some of these obstacles without so-called kind of drowning the rest of the cornea. And it's nice that we have a lot of options to be able to do this today. So keep in mind, trying not to just keep vaulting until you get to where you want to go, because what ends up happening is you keep vaulting, especially like this patient here where they've got superior touch. The more and more you vault, the worse the lens is going to fit the rest of the cornea, and you're going to get a lens that drops and decenters, and then you end up getting more touch in that area. So a little bit of a tip there. Corneal staining, you're going to have corneal staining, and I'll tell you right now, both of these patients who we took pictures of are patients who are doing fine with their scleral lenses, no complaints whatsoever. So I would say on one tone, expect to see a little bit of staining, and this is where your baseline data really comes into a helpful tone, because you can see, is this better? And this bottom picture, this is a transplant patient, but it's also a patient who had Sjogren's. So they had staining way before we put the lens on, and this was actually a little bit better. So keep in mind if it's better or if it's worse. If it's worse, you can look at your different reasons, right? Is the lens touching? If the lens isn't touching, what type of solution is the patient using? So usually most corneal staining can be mitigated by some sort of fit change and or solution change. And don't be afraid to change the cleaning solution that patients use or the application solution that patients use, so that they can get, to play around with some of the different solutions if you've got staining that is out of what's normal for that patient. Talking a little bit about the fluid reservoir, because that's so important in terms of what's actually going on with the corneal health. One of the other things that you'll see, and this is not so much staining, this is what we consider bogging. And you can see there's kind of this just non-specific bogginess. You can see it here in this image as well. Non-specific kind of fluorescein just doesn't quite flush. It's almost like we always compare it to when you're in a hot tub for too long and your skin kind of gets wrinkled up. Again, not a lot of research here, so we don't really know what's going on, but I think that's a fair enough hypothesis. And I have you know, I see this in 70% of patients when they remove their scleral lenses. Typically goes away after 15 or 20 minutes, and I've never seen it cause a problem. So I do think it is similar to that phenomenon of the hot tub, and there's lots of different potential etiologies. Maybe a little bit of a change, certainly a change in the tear foam, but just a change in that tear epithelial interaction. But again, our really only management is monitor it. If it's, you know, combined with some staining and it's at a point where, you know, you've seen a lot of patients and you really are thinking, oh, this bogginess just doesn't look right to me, try playing around with their application solutions. You can try something, you know, if you're in a saline solution, you can try something like a preservative-free artificial tear, or one of the solutions that has some extra nutrients and things. But don't be afraid to play around with that. But I think most of us, as we fit these more and more, become pretty comfortable with this bogging phenomenon. Not to be confused with toxicity here, right? So this one's pretty obvious. This patient in the top and even this patient in the bottom, both of those are going to come in symptomatic. Maybe not with pain per se, because they've probably got a lens on, but certainly this is going to affect vision, right? It's going to, if you get that much staining, you'll have vision affected. This is somebody who had used a preserved solution in their bowl of the lens. So I think this just nicely speaks to using the non-preserved, saying the importance of really educating patients about not having any sort of thing, including a medicated drop, a solution that they cleaned the lens with prior to putting it on, anything on that back surface of the lens that could get trapped under the lens during lens wear. So this is typically managed with education. So much of these complications is just properly educating the patient on correctly using their solutions and that sort of thing. So increasing tear exchange, this one's a little trickier, right? Because we think this is actually, this bottom image is from a paper, and they attribute it to tear stagnation or metabolic waste buildup. So if you think that if you see this on a patient, and then you also notice that that patient has no tear exchange, that would be the time to think, okay, let me see if I can play around with the diameter, play around with the toricity, try to encourage a little bit more exchange of the tears, and see if that helps. But that is a tricky one when you get this staining and you think everything looks good and they're using their solutions right. You sometimes have to go through kind of a few different things. And then, like I mentioned, there's lots of different types of solutions that you can use. And we can, again, talk about that if you guys want in the Q&A, but I won't go too much more into that, except to share just a quick study that actually did, and there's a few studies here. This both were published back here in 2020, looking at a couple different solutions. So Vivian Say at Berkeley looked at a couple different solutions, found no difference in PuriLens versus Adipac, which are two saline solutions. Jen Voigt up in the north there looked at midday fogging with Neutrophil, which is a scleral lens solution that has some of those analytes in it, magnesium, potassium. They found it was safe and good to use and had subjective improvement of symptoms. Didn't do anything for midday fogging, but that's okay. It still made some of our patients feel better. So if you want to look a little bit more into that, but most of the solutions that are available, they all work pretty well, and we have ones that we like better than others. But again, I could chat more about that if you guys want later. Corneal edema, I'm just going to kind of skip through as something that occurs. I think this, again, speaks to the need to measure baseline. So we're never going to know if somebody's got hypoxia unless you've got a baseline to compare it to. So we typically will use the Pentacam. You can also use the OCT for this. You can use a handheld pachymeter if you have absolutely nothing else. But it's good to get a measurement. I like to measure this, and then certainly I'll oftentimes do follow-up pentacams or OCTs at the follow-up to make sure I'm not getting swelling, or to see how much swell I am getting. But certainly if you have patients that have symptoms of blur after several hours of wear, especially in your transplant patients, which are at highest risk for hypoxia, this is that's something that you can use. Keep in mind, you're going to get about 20 to 40 microns of swelling. And here at UH, we use the 50 microns as sort of the, turning point, where if we've got 50 microns of swelling with scleral lenses, we need to make some changes, either reducing the fluid reservoir, increasing the DK, or doing both. Because you can see, as we know, again, I'm just going to skip through this, lots of changes can happen due to hypoxia. Cornea neo being the probably most benign, but certainly will indicate chronic hypoxia. You'll get, this is a graft patient who had active swelling. This is from our friends up in Boston, which you can see here by the kind of mottled appearance. And then even this is with soft contact lenses, hasn't been looked at with sclerals, but presumably could be a similar effect where they had endothelial blebs. This is from Langis up in Montreal. Saw endothelial blebs in contact lens wearers. So we want to make sure we're getting enough oxygen, certainly to our patients' eyes, and that our risk benefit balance is intact. And like I mentioned, the patients with transplants or anyone that has a compromised endothelium, but certainly our patients with transplants are going to have a reduced endothelial function. Here's just an example of one of my patients who is post-transplant, and you can see this I share because I think it speaks of the importance, if you can, of taking global pachymetry. You can see if I were doing a handheld and I just happen to measure in this area here, there's a plus. Plus indicates that it actually got thinner, the way that this map is. These negative numbers, it's just the maps were switched in the subtraction part. So, but the cornea was thicker by anywhere from 100 to 150 microns in certain areas. But if I wasn't doing global and I was just looking, I might just look at that spot and think that my cornea was just fine. This patient was a symptomatic patient, and fortunately, most of our patients that have severe swelling, they're going to tell us. They're not going to know what they're telling us, but they're going to tell us that they're getting blur after a few hours of wear, and we can kind of put the pieces of the puzzle together. But like I say again, if you don't have a baseline measurement, you're never going to know if you got swelling, because the thickness of these corneas, especially transplants, can be a huge range. So you can't just follow a normative database. This I'm just going to skip through. This was just telling us, this is just to, you guys can look at this study if you want, showing us that the tear reservoir is probably even more important than DK, as long as your DK is over 100. More important to lower that fluid reservoir if you want to reduce edema in these patients. There hasn't been a study on this, but I think these images are pretty powerful, and we just know based on all the work Boston site has done, that putting channels, if you can, into some of the lenses can also help with the edema. And I'll take another quick break here if anyone has questions.
You bet. Thank you so much for a lot of those tips that you're discussing there. And I think not the least of which is the comment about the importance of baseline measurements, because you can't compare anything to something without having that established. Interestingly enough, there's quite a few questions related to Progent, HydraPeg, and their interaction, and how do you implement the use of them with your patients?
Yeah, so it's I guess a little bit of a double-edged sword. So Progent will definitely take HydraPeg off, but I also say, but Progent will take HydraPeg off if you want it off. So there's two patients, right? There's patients who do really well and need HydraPeg on every lens, and they can tell. And then you're going to get the occasional patient who doesn't like the HydraPeg quite as much as they liked the regular lens. So I think keeping in mind, if you use Progent, you're not going to be able to have a HydraPeg lens. But some patients, it's more important that the lens be super, super clean than it is that the lens be this hydrophilic coating. So I think it's just a patient selection thing. So if you have a patient who's, I like to use HydroPeg on my patients with like aqueous deficient, a really genuine dry eye, and it's women a lot of the times because it really keeps that lens wet. But if you have patients that are really heavy depositors, so they've got the MGD, typically more of your male population, but I don't want to pigeonhole anyone. But if you've got those heavy depositors, HydroPeg might not work so well for them because it's lipophilic. So they're going to get those lipids stuck onto that lens. So
Sure.
that's your ProGen patient. So I really think of it as I've got my ProGen patients and I've got my HydroPeg patients, and they don't really cross over very much. But I'll tell you, don't use ProGen if you want to keep that HydroPeg on the lens.
Okay, excellent. A couple of other quick ones, and then if your question isn't answered, we'll still have another shot at it after the next segment. Do you change the lens decay or thin the lens design, thereby decreasing the thickness, to decrease the thickness of the tear layer if you have epithelial bogging? Like, do you modify the lens parameters in such a way to help you impact that?
I've never done it. I've never noticed that it anecdotally helped it in any way. So no, I think it's more of just, a fluid being there and either, interacting, but I don't want to speculate, but no, I haven't noticed that changes anything,
Okay.
and I haven't tried.
Severe dry eye that demonstrates filamentary keratitis, scleral lenses an option?
Yeah, oh, for sure.
For sure.
Yeah, we've actually, oh gosh, way back, we actually had with Pat, when I was back doing my residency, we had a patient come in the morning with filamentary keratitis. We put a lens on and the cornea was clear by the end of the day. It'll dissolve filaments pretty quickly. So yes, absolutely. And I've also had patients who like have had, been to our other clinic on the other side and the medical side and gotten filaments kind of pulled out, and then we would put a lens on to protect it. So yeah, absolutely. I've had a lot of people who love to do it for filamentary keratitis.
Okay, great. Just a quick comment. Andy Jackson or Jonathan Meadis will be discussing a little bit about the whole HydroPeg and keeping the surfaces clean in their segment at the end. And then just one last quick one and we'll move on. How worried are you about the pH of sterile saline solutions when they're trapped underneath the lens for any long period of time?
Yeah, well, again, anecdotally, I can tell you not that worried. And if you notice that study I showed, that's a good one to read. Vivian Say did that at Berkeley. They compared Adipac, which is pH of 5, to PuriLens, which is pH of 7, and found no difference. They did confocal on the nerves, and they looked at the permeability of the cornea itself, so found nothing. I'll say, every now and then I've had a patient where they've had a little bit of stinging when they put it in, and I've sort of chalked it up to it being the pH. But no, I don't. I'm less convinced of that now that paper came out, and just the more I've seen people have no issues using, right? Because I mean, Craig, you remember too. It's like that's all you guys had for a while to use was Adipac, and it wasn't like you were getting these toxic corneas coming in.
Yeah, of course. And then, as all things, there are outliers, patient specific, that will react to just about anything. But it's an interesting discussion. Maria, let's close this out and have you go ahead and continue.
Great. All right. And I am going to go through these a little quick. I'm going to skip through them a little bit. So midday fogging, I think we already talked a bit about. I do just want to update us on what the research is showing, right? So I actually we're preparing something for publication here, but this has been, I think a few of us have been looking at for a few years. We think it's probably more patient specific than fit specific. Nobody's really been able to say a certain type of fit causes midday fogging. They can say, oh, if you have more clearance, it seems to be worse, but I think that's just a thicker kind of fog layer. So we think it's something to do with the lipids. Certainly there was a study back, Cameron Posnikov at UAB did a study that found more white blood cells, but whether or not they were active, I don't think they were very active. It does not appear to be inflammatory. And ultimately, I think the best thing we can do is this middle one right here. Use the lipophilic preservative-free artificial tears. I still recommend reducing apical clearance just because it reduces that layer of fog. It reduces the thickness of that. And it's just better for the fit in general to have lower clearance. And then I manage my patient-specific hygiene. Absolutely. And we can talk more about this in the Q&A if you guys are more interested in this. But the take home for me on midday fogging is treat the patient, not the fit, and expect to still have some, expect not to be able to necessarily fix it 100%. I'm just going to skip through these here. This is just more of the basic stuff on evaluating the limbus. I do want to mention, just in talking about the limbus, conjunctival prolapse. This is when it's almost always in these areas. You can see if you look at the elevation map on the cornea, it's reduced or, more depressed in the area, usually inferiorly. So just the way the suction forces work, you're going to get some conjunctival tissue sucked up under that lens a little bit. If it's less than a couple of clock hours, I don't do anything about it. Extreme examples, I actually had a ophthalmologist tell one of my patients recently that he could resect it and cut it for her. I changed her fit to reduce the limbo clearance, and it was fine. So she didn't have to go down that road. So I would say before you go to those kind of drastic measures, like a surgical option, if you reduce the amount of clearance over the limbus, it can usually reduce it enough so that it's doable for the patients. Here's just some examples of a loose and a tight landing zone. These are just a flatten it if it's too steep, loosen it if it's too flat. This is, again, to go back to the beginning, where our scleral topographies or any sort of way of measuring elevations of the landing zone can really be helpful. The other thing I'll say is take images, right? You can imagine describing either of these things, and it's just going to be pretty subjective. So take pictures. I literally just this afternoon was sending videos to the consultant as we were talking on the phone, which we do oftentimes. They appreciate it, and everybody, and you end up getting better lenses. And so this is just an example of a good fit for comparison. But take pictures, share them with your consultants. We'll just skip over some of this stuff. This is just landing zone stuff. Fluorescein can be used. So this is where y'all asked about putting fluorescein over the top of the lens. I absolutely do that when patients come in, because this is a good example of being able to tell where your areas of tear exchange are occurring, right? So this patient, it's right here. These are his toric markers at, about 135 and 135 degrees here, that are showing where the flat meridian is. And so it looks like this other meridian here is probably even a little too flat on that meridian. So fluorescein can be so helpful at seeing how the tears are flowing in and out of underneath the lens, and also just for evaluating your landing zone. And expect to get a little staining where that landing zone lands. But this looks like just a classic kind of impression, but I don't see any areas of hypertrophy of the conjunctiva or laceration of the conjunctiva. So I think this is okay, and you can expect to see some compression. Again, here's an example. This is a lens right off the eye. So, some people might argue that's a little too much compression. I'll tell you, I see these patients a lot. This on the left-hand side is expected, and it is not too much compression for this patient. Keeping in mind, this is immediately after the lens came off the eye. Versus on our right side here, immediately after the lens came off the eye, I've got some redness. You can see visible hypertrophy and some that this would light up with staining here. So right side, I'd change. This looks like an easy toric fit would change that compression along the horizontal meridian. And on this left side, that's within normal range for this patient. and we keep going with that. There's also going to be other conjunctival roadblocks, pinguiculas, blebs. There's lots of different things we can do. This is an example of just a little vault over just a little pinguicula. You can't even tell it's there because it vaults over it nicely. You can truncate lenses. This is an example of something called a precision lift. You lift over those conjunctival roadblocks. Here's a nice example of a spherical lens that's got some shadows because it's resting on this small little pinguicula. And when we vault over it, looks nice and you're not impinging so much on that surface. So take advantage of the many different types of customized designs that are available. And last thing that I'll talk about quickly here today is intraocular pressure. And again, I think I'll leave most of this if you guys have questions. But just to share, you know, we know that the lens overlies the area. Let me skip to this here. We know that the lens overlies, sorry about this, guys. Overlies the area right over where the aqueous humor is drained. So how do we measure this? There's lots of different instruments that we can use. I would say, again, with IOP, the jury is really still out. We don't think that we're increasing IOP significantly in most of our patients. And I know that's kind of a vague statement, but you know, it seems to be fine in most patients. What I would say is get a baseline reading of IOP. And what I do is I measure IOP at least when in that first fitting period, when patients are getting used to the lenses. I'll take the lens off and immediately measure IOP. And maybe in one every 10 to 15 patients, you'll get a slight spike, 5 millimeters or so, which for some patients we know is a lot. So you have to be considerate of what who the patient is. And then we find that pressure will kind of go back down to baseline. So still a lot to be looked at there. We do know that we did a study where we evaluated the optic nerve head. So we actually evaluated this optic nerve parameter here. Didn't see any changes there, which is ultimately the danger of an increased IOP is damage to the optic nerve head. So jury is still out there, but I don't think anybody has to lose sleep over increasing IOP. But be careful in those glaucoma patients. Over-refraction, again, if we want to look at these later, we can, but that's pretty much it for me here. And I think just to conclude, you know, scleral lenses have really revolutionized specialty contact lens management, but we always have to remember this balancing act of risks versus benefits. And so, you know, understanding that they have a really positive impact on so many of our patients and kind of working to manage the limitations so that we can make this modality even better when you know, moving forward for our patients. So fit with what I tell my students, cautious optimism. And I think that you'll make a lot of patients really, really happy, and hopefully you'll have some success in your practice for it as well.
Okay, Dr. Walker, thank you so much. And of course, we have some questions to be answered. But before we do that, I'd just like to take a couple of moments and introduce Andy Jackson, who heads up the specialty lens division for ABB Optical Group, and also Jonathan Meadis, who's the manager of specialty lenses. And Andy and Jonathan are just going to share a couple of slides of some interesting products that actually are going to play right into some of the questions that were already asked. Andy?
Yeah, thanks, Craig. We'll be brief. We know y'all want to get back to the questions with Dr. Walker because she's truly awesome. But we've got a couple of really exciting products. You know, ABB Specialty Division it's probably got the greatest portfolio of anybody in the industry with specialty lenses. You know, are really the backbone of ABB Specialty is our consultation staff. We've got 12 consultants. They've got just experience all over the map. We've got a couple of them that were with Synergize. We've got them from different labs, a lab that I used to own. We've got one of our consultants from there, and we've got a couple of new ones that we've just brought on board, really bright. So we'd ask you to really lean on us for that. Our whole job within specialty is to make your practices more efficient. So accounting efficiencies, shipping efficiencies. We offer our account managers will come in and do business reviews on your specialty business to see where your benchmarks are. And then education is really Dee Dee Reyes, who I hired a couple of years ago. She's really leading the way there, and we've really got a whole platform of education, whether it's for you, the doctors, the staff. We're now doing virtual wet labs where we literally, everybody that can watch it and watch the doctor fitting the lens, and we can talk through it with you. So got all these things we can do for you. Here's our portfolio. We've actually got 12 different scleral lenses. We manufacture 8 of them. We distribute 4. We brought on poor Boston Sight. We launched their lens in the middle of COVID last year, so we're going to relaunch it at GSLS next week. It's a great product, along with we've got Amplify from Art Optical, Atlantis from XL. We've got some great products from a lot of the other people we distribute for. Gas permeable, the prime warranty. I instituted this a couple of years ago. We just want to make it simple for you. So we want you to order a lens, know exactly what you have the cost in the lens. All your exchanges are no charge. 90 days on a single vision, 120 days on a specialty lens. You don't have to send anything back unless the patient cancels. So we just try to make it simple. Educational opportunities, I talked about a little bit, but basically you can work with your staff. We're just starting a new dry eye division that we're launching next week, and Jonathan's going to talk about that a little bit. We're going to have education in that as well. So I'll let Jonathan touch on that here in just a little bit. Next slide, please. Yes, our Scleral Starter Kit, we just launched this last week. Believe it or not, it took us 2 years to develop this, but we wanted to make sure that we could give you products that had everything a new scleral patient would need, and they can get everything from you, and they won't go to Amazon, because none of this is going to be available. The Scleral Saline, the Vibrant View Scleral Saline, we put a 12-day supply in this starter kit. We put a bottle of the Tangible Clean in there, which is about a month's supply, 3.4 ounce. We've got 2 DMVs. We've got everything you need to start a scleral patient. So you order a new scleral patient from us, you're now going to get this kit. And we'll have a nice little card in there for your staff to remind them to go ahead and order the 3-month supply of 100 5 ml ampules of the Scleral Saline and a 12-ounce bottle of the Tangible Clean. So we're trying to make it easy. They won't be able to get it anywhere else. So here's the products I just talked about, the Scleral Saline. We've also got, if you can go right back to that, Dr. Argia, the contact lens hand prep. We've got a hypochlorous product that it's really an extra layer protection for the patients, for contact lens patients, whether it's a soft lens patient or a gas perm patient. They can spray it directly on their hands. It's hypochlorous acid. It's totally compatible with the contact lens. You can spray it on your hand, stick the lens on your hand when you're on the go in the car, put the lens in your eye. Hypochlorous is the same thing they use in grocery stores spraying on your vegetables. I mean, it's totally, your white blood cells actually create it, so it's totally compatible with the body. So we introduced that this past week. And then we've got the lid and lash spray you can see for dry that we use that for an in-office treatment, or the blue bottle is for the patient to take home and spray. So Tangible Boost, we're launching that at GSLS next week. It's going to be available starting in February. It's basically, like Dr. Walker was talking a little bit about HydroPeg. If you've got a patient that loves HydroPeg, we all know after 4, 6, 8 months, it starts wearing off. Boost will be a monthly process where they put it in the Boost and it builds back up that layer of HydroPeg, so it gets them through the year with a nicely coated lens that wets really well and stays really slick. Jonathan?
Yep. So I think our first slide should not only say greater value, but greater revenue, greater profit for the practices, because a lot of those things Andy just talked about, the Boost, the Clean, the Scleral kits, the hand prep, all those things are things that are going to generate revenue and profit for the practice that were previously going to online sources. So our new product, our new dry division, we're going to be, you guys are actually seeing this before even any of the ABB account managers are, is going to be Regenerize. And Regenerize is coming from, it's going to be the first and only sterile biological eye drop. So when we looked at this opportunity, there's 40 million patients that experience dry eye, right? So right now you write a script, the patient goes to the pharmacy, they get the script, and there's no economics for the practice to be able to monopolize or to monetize that. So this is going to be a product that we're going to be featuring at GSLS, where you'll actually be able to either ship it directly to the patient, and we'll do that on your behalf, or you'll be able to inventory it right in your office and hand it right to the patient for better satisfaction. But just as a little teaser, this is a $1.8 billion category right now. So come stop by at GSLS and visit us, and we'll talk to you about it. Our fastest growing part of our custom or ABB specialty lens division are our custom soft lenses. So as most of you know, Cooper has discontinued the HydroSoft product. There aren't many options in that realm for products. HydroSoft was somewhat limited as far as material. With ABB, Concise Custom, and our definitive products, we have more options for materials, as you can see here. We also have the ability to upgrade the patient into a silicone hydrogel, as well as much better parameters. We've actually added additional shifts in our lab to try and keep up with the demand for these products. The biggest thing against the market leaders in this realm is our turnaround time. We can get these lenses to you in about a week with any of our parameters that we offer, and it's been really a big boom for us. So another thing that we talk about is ABB's business solutions. So we have ABB Analyze, our auto ship program, Verify, and our Educate and Connect. All these tie into everything that we're kind of talking about providing greater value to our practices. We're a one-stop shop for all of your optical needs. And I'll talk a little bit here about Verify. Next slide. So Verify is a tool that's been around for just about a year. We launched it at Visit Expo West. It's a tool that kind of drives patients back into the practice. You can maximize their current vision benefits. There's a real-time component to it where it's an on-demand functionality. It can integrate with your practice management system depending on what systems you have. It's something that's been very helpful. The return on investment for Verify is a minimal of 20x, and we can discuss that with you also at another time, or you could reach out to your ABB account manager.
That's great. Thank you, guys. A couple of comments before we turn this back to Dr. Walker. For those of you that aren't aware, GSLS that was mentioned is the Global Specialty Lens Symposium. It's an all virtual meeting this year that begins next Thursday. It's 100% no charge, and it offers CE plus the opportunity to interact with some of the greatest manufacturers like ABB Optical and visit their booths and learn in more detail the products that Andy and Jonathan just brought up to us. So if it's next Thursday evening, Friday, and Saturday, half the day, Global Specialty Lens Symposium. A couple of questions here. I'm going to answer or get to an easy one here first. There's a question about how to open up an account. I will just say that I will turn this information over to Jonathan, and somebody on his team will contact you directly on what that means. I have a couple of questions, Dr. Walker, related to IOP. One is, how big of a deal is it really? And you already did answer that kind of. The second is, though, more down in the weeds. And that is, have you used the diatom tonometer to measure IOP while the lens is on the eye? And if so, is it valid, or what's your opinion of that?
Great questions. And yeah, IOP, actually, if you're plugging GSLS, we actually are doing a research forum along with GSLS. So it's next Sunday at 10:30 to 11:30, and we're gonna have people who've published on IOP. That's gonna be the session. So it's all on the GSLS website. So if you're interested in more on IOP, but I will answer your questions. So how big a deal is it really? And what I would say is not a big deal, as big of a deal as you think it is. But there's always going to be those patients who, if you've got glaucoma and you're putting this lens on, that's, where your risk is maybe going to get higher. But, I'll tell you, it's not a doomsday. Nobody's been able to really say, definitively that we definitely increase IOP. But I do think it's worth screening and worth looking at our patients. If I were to venture how many patients were actually, changed IOP enough that it would potentially cause long-term damage to their optic nerve, I'd say maybe it's 1 in 50 or 1 in 100, but it's, I don't think it's no one, but I don't think it's most of our patients. That's to answer that. Yes, I have used the diaton, and I will refer you to a paper that we published on it in OVS in September, just if you want the proof, but I do not find it particularly reliable. I know it's been used in a few different studies. We used it, we compared it, 100 measurements taken without a scleral lens on to 100 measurements taken with the eye care, and there was zero correlation. So we would get 20 with the diaton and 7 with the eye care, or 22 with the eye care and 12 with the diaton. So really the results were all over the place. I think there's a place for it, but I think that and it could have improved in its reliability. Technology has its way of doing that, as we know. So I don't want to throw it under the bus too much, but my experience with it has been that it's not very reliable.
Okay, and part of this whole area of elevated IOP is interesting because it should be said temporary elevated IOP. And that's not uncommon within the eye care field. For instance, in surgical procedures, it's not uncommon to elevate the IOP purposely, prior to surgery or during the surgical process. And it's still is kind of hanging out there as a really interesting subject on how big of a deal it will be.
Yeah, and I'll follow up on one quick thing that you allude to, and it's a really good point. IOP fluctuates when you stand up, when you exercise, when you cough, we all the time have constant fluctuations. A normal eye is able to compensate for those fluctuations. So in theory, a normal eye should be able to, if there is an increase in the outflow resistance, which would be what was happening in the theory with a scleral lens, right? You increase the amount of resistance to outflow. Then the trabecular meshwork actually has cells that should be able to sort of smooth out that so that it changes upstream, and so there's not as much resistance. So a normal eye should be able to compensate. Again, it's those glaucomatous eyes that can't compensate that you have to watch out for.
Yeah.
So thanks for bringing that up.
For sure. So Maria, tell me, do you think, or can you supply data that says that fitting outcomes are higher with the use of scleral topography versus diagnostic lens fitting?
That's a good question. Nothing that I could refer you to off the top of my head. I will say that there's been a few studies that have found better fits. So maybe not looking necessarily at subjective outcomes, but better centration with a customized, and not saying a customized, but with a more, a lens designed off of a topography. And then there are some studies like out of the Netherlands with the visors that definitely show that creating more asymmetry in the landing zone gives better subjective, and they've looked at a ton of patients. And so that would seem to indicate that by a more customized landing zone, now they weren't necessarily using scleral topography, but just by careful assessment and ordering more customized landing zones, they were getting and continue to get better success. We also do know, based on the data, that really only maybe a quarter to a third or even less. I think they even found, like in that one study, like 6% of patients had a spherical landing zone. So I think the more we learn about the shape, the more we learn that there's a lot of asymmetries in patients' shapes, and that they kind of on the other side tend to do better with asymmetric landing zones. So I think the data is very much kind of able to be connected together, but not a specific study looking at,
Sure. For instance, one thought that has come across in the last 7 to 10 months is because of the COVID concerns, because of the diagnostic fitting, that possibly using scleral topography to do the initial fit is really the way to go. And I know we're not there yet because of the lack of proliferation of the different topographical units, although they're increasing routinely. But do you see that as a potential way to be able to improve outcomes, excuse me, and also not be worried about slapping a diagnostic lens on a patient's eye?
Yeah, I think, and I'll tell you, I do it for about 50% of my fits. I let my students choose their lens, so depending on what lens they choose, I'm fully supportive of the empirical. I love to do that. So I'll often order just based on what I'm getting on the scleral topographer. You do typically, I find best practice is still to put a diagnostic lens on for your over refraction. Because it's hard, because you don't get a good manifest, so it's hard to empirically figure out the lens power unless patient has been in a rigid lens in the past. But it still saves so much time, because if you've done the scleral topography, it's going to tell you what diagnostic lens to use, and you can be pretty sure it's going to be a one that's usable. And then you put it on, you do your over refraction, and I'll glance at the periphery, but you're not really worrying about having to make those decisions at that point. So yeah, I absolutely think that's the way. Technology, it's hard to fight with technology. It just makes our lives easier, and I think let's take advantage of it.
Yeah, definitely. So Dr. Maria Walker, do you have any closing comments?
Yeah, nothing in particular. I thank you guys for, staying on a little extra here for some of these questions. But no, I think it's been a pleasure. I really enjoyed. I always like doing all the things with you, Andy, and everybody at ABB. It's a great company. I can't. I've done a lot of work with them, and it's really nice to have all the different lens options. And so you've found a good family with ABB, I think, for sure. So thank you guys for having me.
Oh, Maria, thank you so much. It's really special to have your insight. It's been a phenomenal presentation this evening. Andy Jackson and Jonathan Meadis, thank you also so much for weighing in on what's the latest and the greatest from ABB. And of most importance is thanks for all of the attendees that signed in tonight and were willing to spend a little bit over an hour chatting about scleral contact lenses. Always a very interesting thing to discuss. Everybody, please be safe. And remember that the recording of this will be up on the ABB Optical site within the next couple of days, along with a special feature is right after this, Dr. Walker and I are going to talk about 4 or 5 key questions, and she will be answering those as FAQs that will be posted on ABB Optical's website also within the next couple of days. So thank you so much, everybody. We really appreciate you participating and hope to see you again in around 3 months when the next in this series of ABB practitioner webinars is taking place. Good night.